So there's a lot in this chapter. It's a relatively big chapter. It's in the special populations group though, so this will be grouped with geriatrics and abuse and neglect, and they kind of roll it all in here. So we're going to go through this pretty fast. I'll check, make sure it's posted. If not, I'll get it in there before we leave for lunch. So I don't want to rush it, but there is a lot in here, so we need to get it knocked out. So if I go too fast, I guess I'll just apologize in advance. I remember in EMT school, we didn't talk about pediatrics. When I was in your shoes, we didn't talk about pediatrics. Do you find that odd? Yeah, that's how young the profession is. We didn't have a pediatric module, if you will. And there was an Emergency Medical Services for Children Act passed by the feds circa 1988, 89. About the time I was in your seat, they were developing curriculum for pediatrics. Once I graduated and became a paramedic, I had to go to an additional class just to study pediatrics. The mandate was, if you're going to renew, you got to have this course. And so we took this pediatric course. And now when you get to paramedic school, you'll take a course called Pediatric Advanced Life Support, or PALS. That's the sister to Advanced Cardiac Life Support, or ACLS. And if you're a nurse in a hospital, if you're a paramedic on the streets, those two courses are usually required, ACLS and PALS. So there's a lot to it. And I think one of the biggest problems we start with is we don't even know what a pediatric is. And if you ask the federal government, I think you guys can ride your parents' insurance till you're 26. Mm-hmm. That's how I have a tractor now. It's because my kids aged out and I didn't have to pay the insurance premium anymore. So I got to buy me something instead of paying insurance. So they don't even know. So you're considered a child by the IRS until you're 26. And I've asked this question 1,000 times. How many of you still see your pediatrician? And Gus probably still sees his pediatrician. And one day he's going to go in there and say, you need a big boy doctor, Gus. Right? Because I know he's 17. Is 17 a pediatric? Yeah, it still kind of is, isn't it? So, especially if you're my age, all of you are pediatrics. So by definition, infancy, first year of life. Who did we look at last week, though? What did you call those little kids last week that were newly born? Neonates. So first year of life, an infant is a neonate, but a neonate's not necessarily an infant. Toddler 1 to 3, preschool 3 to 6. That's when it starts getting fun. Toddler, terrible twos, all that stuff. We've heard those stories. School age 6 to 12, and adolescent 12 to 18. So it's all in here together. That's a big range of stuff, isn't it? Isn't that a big range of stuff? How much change is there in the body between neonate and 18?
A lot.
What's one of the big milestones?
They get bigger. Puberty.
You're right. Yeah, you're right. What else? What else?
They can talk.
They can talk. They're easier to assess, or maybe more difficult. Sometimes I think I could talk to an infant better than I can talk to a teenager. But other physiological changes. We'll do it this way to kind of take advantage of time. What else do you think changes?
Weight.
The weight? They get bigger? What about proportions? So the head actually gets smaller in proportion to the body. The infant's head's really big in proportion to the body. The airway. So I'm going to ding you here for a minute. The airway is more narrow. It is more funnel shaped. So the younger you get, the narrower the airway and the more funnel shaped. What is that? How do you think of a funnel shaped airway?
Goes from a big opening to a small opening.
Okay, and what happens if you drop something in a funnel? At some point it could stop, right? Because the funnel is consistently narrowing. What about foreign body airway obstructions in these children? More common, less common?
More common.
More common because of the funnel-shaped airway. There's a change in the epiglottis. There's a change in the epiglottis. The epiglottis becomes a more prominent figure in the airway. It actually changes its shape. and you think about the child nursing all the time and having to swallow all the time and still breathe, those are the reasons for the changes in the epiglottis. But it being bigger, there's a disease process called epiglottitis we'll talk about here in a little while. The narrowest portion of the pediatric airway. The narrowest portion of the pediatric airway is different than the narrowest portion of the adult airway. The cricoid cartilage is the narrowest portion of the pediatric airway. I don't have to really deal with that as an EMT, but as a paramedic or an advanced EMT, I have to deal with it because when I stick an ET tube through the vocal cords, I really don't need that cuff that's on the end of it to seal it because I've got the cricoid cartilage and that will kind of make a seal. What it means for the EMT, it just further compounds a foreign body airway obstruction. Cool? The head's really big, another milestone. The fontanelles seal up at what age? When do the fontanelles grow together and fuse? They should be done by age 18 what? 18 months, yes. 18 months. So that's another milestone in the development. What else? More of a non-anatomical development, if you will. More milestones in growth in life. Like your mom probably recognized this. When you could walk? What age should you be able to walk? We guessing or we know?
Yeah, like 9 months.
I think it's 1.5, right?
Think it's 1.5.
We feel like it.
When they feel like it. About 1 year. Somewhere around 1 year they should be upright and at least starting to try to become bipedal. There may be a give or take on that, but somewhere around 1 year. Well, if it's 2 years out, we have a developmental issue. If you're not walking by 2 years, we have a developmental issue. And so we have to look at those things when we assess the patient, just to know what's normal. You're at a disadvantage, I'll say some of you. I'm trying to think, other than the old guys in the room, Huckabee. Anybody else have children? You don't, did you say not that you know of? Oh. We talked about that last class, okay? How to avoid that, Hunter. So I hope everybody's up for the holidays here. I mean,
Do you have grandkids?
no, I need some. So if you want to volunteer any, I'll spoil them for you. But I'm ready. I don't think the way my kids are going, I will have any grandkids. I don't know what's wrong with you young guys and girls, but guys really. 0 to 2 months. All they do is sleep. It is normal for them to lose weight in this age group, especially in that first month, first few weeks after they get home. It's normal to lose weight because they're adjusting to a new feeding style. They have to thrive for their food now. We kind of talked about that the other day. They cannot tell the difference between parents and strangers. I call BS on that. Maybe the dad, but that baby should know the scent of its mother, the heart rhythm of its mother, the voice of its mother. I'm not saying that dads can't do that, but dads did not have that child in them for 9 months. That dad did not have the vernix on their belly. Okay, that dad did not provide colostrum. So let's be real about this for a moment. If they bonded with their mother at birth, they know their mother. And so we kind of take that into account when we're dealing with a kid that's in distress. Do I have to take the kid from mother to work on it? It depends. I mean, CPR, airway management, absolutely. Sick, high fever, epiglottitis, drooling, inability to swallow. I don't want to take it from the mother because it'll piss it off and then it'll cry. When it cries, the epiglottis will get mad and the epiglottis will close. And the word for that is laryngospasm. Remember that from the other day? So, ding ding test question. Drooling, high fever, irritability, do not piss the kid off. You're worried about a disease process called epiglottitis, and that's usually viral. It's got a sister disease to it called croup. C-R-O-U-P. So you got epiglottitis and croup. I'm giving you the test question here. And you need to differentiate, to some degree, the difference between epiglottitis and croup. Croup is a seal-like bark. So if you've ever heard a seal bark, that whatever seals do, that could be epiglottitis, but it's likely croup. If you take the croup kid, the croupy kid is how it will be determined. Moms like to say that word, croupy. When you take that croupy kid, or the kid with croup, into cold or cool, moist air, their symptoms subside. That doesn't mean they don't need to be evaluated, but if you go into the house, it's dry in the house because it's wintertime, and these are usually winter-borne illnesses in cold and flu season. The kid's got the seal-like bark, can't seem to catch his breath. You take him outside in the cold air to go to the ambulance, and it's kind of misty on a nice, cool winter night, and he goes to sleep. That moist air hits that throat and calms it down. That cool air hits the throat and calms it down. If you're a parent, you can try standing next to the shower running on cold. Don't get him in there, but just stand with it and let the mist off the shower. If that eases the cough, then you have a condition called croup, which is just inflammation and irritability. Epiglottitis, high fever, drooling, because it hurts so bad they will not swallow. We don't want to look in that airway. We don't want to probe. We don't want to go, hey, stick your tongue out and go, ah. We don't want to do that. Another high bullet point right here in this age group. They should not have a fever. They should not have a fever in this range. They have so much passive immunity from their mother, they shouldn't get an infection. Therefore, if your infant has a fever, it should be treated as a high-level emergency. You're probably looking at meningitis. You're probably looking at meningitis. It could be other things. Just realize they should not have a fever.
On the croup thing, do you give them albuterol?
We don't, but they probably not albuterol because that's a bronchodilator. So is the steroids they'll give them, but the steroids have a more longer lasting effect. It's not a disease of the lower airway, and that's what the albuterol, the bronchodilator, would do. It's just an inflammation of the throat, the tissues in the throat, and they'll give them prednisone or something like that to keep that down. They won't even try to treat the infection because it's usually viral. Okay, so they should not have a fever in this age group. If they do, take it as an emergency. By the way, you should already know that from your last lecture. They're predisposed to hypothermia. They have a high body surface area to mass ratio. And I explained that one day over on the board. They have a whole lot of skin for how much they weigh. You weigh a lot for the amount of skin you have. So that's the difference, another difference in pediatrics and adults. They have a high body surface area to mass ratio. And they can't tell you they're cold. They can't dress themselves. They also can't tell you they're hot, so that's a consideration as well. Without that ability, it's all up to the caregiver to make sure they're dressed appropriately for the conditions. Sometimes we overdo it and get febrile seizures. Okay, let me move on through this here a little bit and get you to the things that matter. I want you to pay attention to that with the epiglottitis, because they will use that on you in a test question. We don't want them to get upset when we're dealing with a drooling, epiglottitis, inability to swallow kid, okay? I'm trying to drive that home to you. About 12 months, we talked about them becoming mobile, bipedal, starting to walk, and now they fall downstairs, they get into cabinets. And between 1 and 2, they're going to find everything in the home. And so that really predisposes them to exposures. And, this is where you hear the terms child-proof your house. This is where they find an object and will stick it into something that looks like it will fit. A paper clip in a electrical socket, marbles in the mouth, up the nose, whatever they can find. They'll stick it in orifices, or they'll stick it into things they shouldn't, or they will taste things, because that's how they learn their environments, by taste. Everything goes in their mouth, from pennies to just all kinds of nasty stuff. We were at SeaWorld one year and my son licked the table at McDonald's because he dripped ice cream on it, and I like to have thrown up because he was licking the table. So they're exploring their environment and they have no rationale for doing it. Another key point, we call this the 30-foot assessment. You walk in the room, you see the kid back there, you're assessing the kid before you ever touch the kid. There is a triangle, if I may show you, another triangle with these kids, okay? This one's called the PAT. And it's the Pediatric Assessment Triangle. One of the things we're going to look at is work of breathing. Work of breathing. How well is that kid breathing? Can you tell me what would be okay breathing, or normal breathing, or non-distressed breathing? Can you tell me what the kid would look like where you could clear that off and say we don't have an issue there? Maybe it's easier for you to tell me what it looks like when they do have a bad grade here, if you will. What's a bad grade look like there? What's a bad assessment look like on work of breathing? And I'm doing this from across the room. I haven't even touched them yet. I'm not even within 30 foot of them, but I can see them.
Not breathing enough.
And they're using axillary muscles?
Keep going. Yeah, good.
Color changes.
Color.
Shallow.
Shallow, accessory muscle use, not breathing,
Positioning.
wheezing, grunting,
Quicker than normal.
quicker than normal, slower than normal, flaring nostrils. In the younger age group, especially the infant, would you say they are predominantly mouth breathers or nose breathers? Don't guess, be educated.
I think it's new.
Why?
Because I don't usually see babies with mouths open.
Their muscles and everything to open their mouth up.
Every time I hear a kid running around, he's like, breathing.
I'm talking about this little infant, this up to 12-month guy.
No, it's mouth.
Is it mouth or nose? They're predominantly nose breathers. That's why they got the little turned up nose, because they're usually buried in a boob. They usually have something in their mouth, and so they're predominantly nose breathers. So when we get into these cold and flu seasons, get these upper respiratory infections, the work of breathing changes because they are using their mouth to breathe. Somebody said that. Luke, that may be where you were coming from there. They've got their mouth open and they're gasping, or they're air hungry. We use that term, air hungry. So instead of milk hungry, they're air hungry. So yeah, you understand what work of breathing looks like in an infant. Pay careful attention to the grunting. And then we look at their appearance. So what's a bad appearance? Blue. Pale. Mottled. We use that word mottled.
Inactive. Like,
Inactive.
sort of.
Well, you're over on this side, so I'll go ahead and give it to you. Muscle tone. Are they limp? And you can even tell an infant when they're limp. I mean, it's just something doesn't look right about it. There should be some tone. Remember those reflexes the other day when in the APGAR scoring, you know, if you hold their legs, do they try to pull it back?
Oh, they're quiet.
Huh?
They're quiet.
Quiet? Inactive?
Their eyes should be open.
They sleep a lot, but where do you get that information, do you think?
Small.
Parents? Especially if they're like, they won't arouse. Then I can't wake them up. So that's called the Pediatric Assessment Triangle. And those are the three areas of that. You see this a lot in other textbooks. I'm not 100% sure it's in your textbook. But it's just a common sense approach. You walk over, hey, they don't look good. Why don't they look good? Because you can't talk to them. You can't talk to them. You could. You won't get much feedback. There's another ding-ding moment here. We do a toe-to-head assessment. Now, in your adult assessments, we went head to toe. The head to toe survey. Well, these are toe to head. Can you tell me why we change it? Why don't we start assessing the child at its toes?
Because they can get freaked out.
Yeah, they're going to get freaked out if you go right for the head. 100%. You're correct. You gain some trust. Can I start at the head? Yeah, if they're limp, blue, not breathing, absolutely. How much information have you gathered from that versus now that you're standing at them, you can touch them? Where's the majority of your information at? From 30 foot, isn't it? From 30 foot. You don't really gain that much more by touching the kid. You'll get a temp, you'll get a pulse rate, arousability, because we can't do that A&O times 3, can we? So we have to change our assessments up quite a bit. Do painful procedures at end of assessment. Any of you going to cause pain? What procedure could you do that could cause pain? CPR. You're right. You aren't giving injections.
Freaking out the baby.
Just realize once you freak them out, your assessment's probably over, right? But Billy, if I can freak the child out to the point to where they're crying and mad at me, oh, I'm so relieved. Why would I be relieved if the kid is crying and freaking out on me? They're breathing. They have the ability to be irritable, and they're responding appropriately to irritability. Those are all good things. I hear a kid fall in the background or something go down and I hear a scream, we're good. When I don't hear the scream, I gotta go look. Because what's going on? Warm your hands in the end of the stethoscope. Yeah, it's just because you'll freak them out with that. I'm not going to talk about it here in great detail, but if you have a child, and usually you don't know here yet, but if you have a child with a developmental delay or an autistic type disorder, you really have to change your approach to these and do things quite a bit different because they do have some separation anxiety. Things are about to get wild. So from 12 to 18 months up to 2 months, they're really starting to put things in their mouth. The baby food's coming on board, and then mom thinks a French fry at McDonald's is a cute little thing, and they can't really chew it, so the choking risk goes way up. And you know, you've got to be aware when I walk in, difficulty breathing, they're grunting. This age group, it could be choking. If they're still in the bassinet at 6 months, may not be so much choking unless a pacifier went bad or something. But once they're mobile, this risk goes way up from almost 0 to very, very high. So you got to take that into account as you assess them. There's a high probability they've got something in their mouth or in their airway. The toddler, the terrible twos. This really comes on board right here. May have stranger, you've heard of stranger danger, right? This is starting to be taught. Not only is it taught, it's also just an innate response. It's like, I don't trust anybody but my parents. If they don't trust their parents, be highly suspicious of abuse. If you walk in the room and the toddler runs to you and says, take me away, now I'm kind of exaggerating there, but when the toddler doesn't have any separation anxiety, like, this is weird. Why do they have so much comfort with me? You should not like me, but you something's up. You see the teddy bears, you see airway devices, oxygen delivery devices that look like little stuffed animals, but yet they have oxygen tubing so they can hold that baby or that stuffed animal and get blow by oxygen. They're really fascinated, and you can blow up you used to could. I don't think you can blow up a nitrile glove anymore, but the old latex gloves, we could blow them up and make peacocks and things out of them, and they, play with this while I listen to your lungs. Play with this while I listen to your belly. There's that toe-to-head assessment. If this kid has been to the doctor before, they understand that vaccinations, the first words out, if they can speak, are going to be, Am I going to get a shot? Is it going to hurt? Some of you probably still feel that way, Gus, don't you? Like, I got to go for my checkup. Do I get a shot? I mean, I still do it. I'm 55 years old. I go to the doctor and I'm like, shit, I bet I'm due a tetanus shot and I don't want that today. But you go ahead and take it, don't you? Yeah, we still have anxiety over injections, so imagine what a kid feels. So keep that in mind. You got it as an EMT. I'm not allowed to give any. All right, so you can just tell that up front. I'm not allowed to give any shots. Back to it, I don't think there's anything you should do to cause them pain, unless you're splinting or using a tourniquet or something like that. But and I wouldn't do that last. So if they were hemorrhaging, I wouldn't certainly wait till the end to do it. I have seen children who have been to the doctor so many times by the age of 2, maybe even some corrective surgeries, that this is routine to them, and they don't freak out. So you take that into account as well. It's like this child's had 3 surgeries on a cleft palate, and they're pros at this now. They're pros at this. And if they're that's a good word for the care team. 3 to 6 years, they start confabulating. They think maybe they're hurting because you. How many times have they heard, if you do that, you're going to get hurt? If you do that, you're going to get hurt. So now they're hurting and they think, what did I do? What did I do to deserve this? And they make stuff up. And they don't know that they have a hard time reasoning that something that they did wrong last week and got punished for isn't the reason they're hurting today. We do that as adults, I think. I'm going to blame my injury on something you did to me a long time ago. And there's always the airway risk. Okay. Never lie. And that's a big point to take home, possibly test material right there. Never lie to them. What happens if you lie and they find you out?
They won't trust you.
That's it. It's over. And you're not doing yourself you're not doing your peers a duty there either. If I lie, then they all lie. Anybody, you told me you were a good guy, Mr. Cop, Mr. Fireman, and now you lied to me. Everybody goes off. They all lie now. So never lie. That doesn't mean I'm going to have to stick this ginormous needle in the bottom of your foot. But I have to do this. It's going to hurt a little bit. But I've had it done to me, whatever you can do. Some of you aren't very good with kids because you've never really been around them too much. And that's a disservice to being young. Modesty is developing. They understand private parts, so deal with that the best you can. In other words, don't go there unless there's an injury there. And then if you cover it up and get rid of it, hey, they're happy. They're happy, even on a minor wound. We're starting to get up to 6 to 12 years of age. This is a troubling time too, because we know what it means to die. We're very concrete thinkers at this moment. This will be the first question out of these children's mouths. Am I going to die? Every injury could result in death to them at this moment. Some of it is an irrational fear of death, a phobia, if you will. They get really locked in on this, where almost a hypochondriac looking scenario, and sometimes they do end up developing that disorder. I just hate to put this in here, but in this group there are, and as the females enter pubescence earlier, you're really bordering in on childbearing ages here, and it's too easy to dive off into abuse, and I hate that because it is a common, I say common, it's prevalent. I think one of them I'd call that prevalent. That's too many, but it's starting to go on here. How many kids at this age probably have access to iPads or cell phones or the internet? And they're pretty damn good at it. They're pretty damn good at it. Those devices are very intuitive. You know, your iPhone doesn't come with an instruction manual, but you know how to use it. These kids know how to use this stuff without being taught. It's very intuitive. It is vibrant. There's some research out there that their eyesight and the visual centers of their brain aren't developing properly because they're seeing things in such high detail. It's better than reality, isn't it? It's got more focus and more, what's the word I'm looking for? Definition. It's high def. It's higher def than life. It's vibrant. You got bigger colors, better colors, brighter colors. And because they're always looking here, they have issues seeing far off. And that's even in an adult. Sometimes we have to have corrective eyewear just because we're staring close all the time. Abuse is easy to come in at this age group right here. It's easy to come in. So I hate saying that, but at this age group, we have to start removing our surprise hat and go, could this child be sexualized at 10 years old? And the answer is absolutely. Absolutely. So this starts becoming an issue as well. Especially when, and you'll pick up on that when you start hearing weird things or seeing things that are odd to them. Focus not on mom but on the kid. You can kind of start moving your assessment more adult-like. Parents will do this, but I don't know that you should do this, and it comes to this bullet point right here. If you're good and you'll go with him, we'll stop and get ice cream on the way home. If you'll let the fireman, you'll let Mr. Fireman listen to your chest, I'll buy you a toy. We don't do things like that. We're keep it simple. Keep it simple. Once you get into a debate with this age group, you'll never get out of it. You will always lose. You will always lose. Adolescence. Oh boy. Sorry, Gus. Sorry, Gus. Gus, you're such a good guy. I really enjoy having you in class, and thanks for allowing me to pick on you a little bit. I hope it's not abusive. Okay, very good. Some of you are real close to this age group. At least you remember it. I'm having a hard time remembering it. And what I do remember from this time in my life was the really good things and the really bad things. But the everyday things I don't remember too much. Puberty begins. So, wow. It begins earlier for the female than it does the male. Males have to play catch up. There are some males who leave this age group without puberty even starting, and that's becoming more prevalent. That makes a problem for us in the American Heart Association world when I apply an AED and I don't know how old the kid is or the individual is because they're unconscious, they're technically dead, and I'm supposed to do CPR on them. Do I use the PD pads or the adult pads? Y'all remember that debate? And I think your test back then said signs of puberty, we'll use the adult pads. Signs of puberty. I think we can have an issue with that. I think you got to use some common sense in that as well. So you're a little beyond a basic CPR course, so please take that in consideration. If they look like a big old boy, remember the AED is based on weight. It's based on weight. So I know of some kids in this age group that are big. They're heavy. May not be appropriate for them, okay? So you got to kind of change that rule that the AHA teaches you. Time of experimentation and risk-taking. Now, Gus, I know you've never experimented with any drugs or anything like that, so thank you for that. But sure, peer pressure, right? Hey, take one of these. You'll pass that test. What's a common drug that's in these age groups that gets passed around in high schools? You should know. Huh? Adderall. Yeah. What else? Weed. Nicotine. Any others? We got weed, nicotine, Adderall. Xanax. Alcohol.
Cocaine.
Depends. Depends. My bad. I'm sorry. Depends on what area of Oklahoma you're in, but
Coke was everywhere in my school, golly.
Was it really?
What school is it? Williams, Arizona.
Bottom high school, like that.
Bonham High School? They got cocaine in Bonham? That's kind of a high-end drug, man.
There's a lot of cocaine around here.
Yeah, it's everywhere. Stuff's everywhere. Stuff's everywhere. And we're getting the fentanyl crisis, and we can talk about that more if we need to, but I don't want to. But gosh, and are they lying? They know how to lie now. They know how to hide it. Is there a risk of sexually transmitted diseases here? Is there a risk of pregnancy here? Yes, and yes, and yes, and yes. And so it's a very difficult group to deal with. And who do you usually have hovering around while you're doing your assessment? A parent that they may or may not feel comfortable talking about some of their issues with. So you and your partner need to have a good correlation there to say, hey, can you give them that nod. Take mom, distract mom, and we'll have a question. We'll have a conversation. Be sure you be careful with that as well, especially if you're doing an exam. EMT of same gender should do physical exam if possible. That's just good practice, but it's not always possible. Therefore, witnesses or the other guy in the room or something like that. I don't know about you going to your primary care physician or your doctor, but when there's an exam taking place, they get the nurse in the room there with you, depending on the situation with that. Let's see, what else we need to talk about? That's about it. So I've already been through some anatomical differences. We'll say it one more time. The head is predominantly bigger. You may hear this in the test question as they have a very large occipital or occipital region. The occipital bone is the bone in the back of the skull, and it's very prominent in a kid. So here's another potential test question you'll see, if not in here, on the registry. If I need to maintain an airway of a child, I have to accommodate for the large occipital, which means I need to put something under their shoulders. The test will probably say a rolled towel, but it could be a rolled t-shirt, it could be a hoodie, it could be whatever. But you just need to keep a neutral alignment in the airway. The younger they are, the worse that will become. So I can't lay the infant on a hard table and try to do CPR on them. If I head tilt, chin lift, I'll exaggerate it. The best thing to do is put padding under their shoulders to maintain neutral alignment of the airway. We cool on that? That cricoid ring, remember from your airway lecture, we have that really stiff ring in the trachea. That's not hardened yet. And so their airway is easier to collapse. That cartilage isn't hardened, it's still very pliable and soft, so the airway's really, really easy. The tongue is proportionally larger, the occipit's proportionally larger. I don't think we need to know this as a EMT, but look how anterior the adult airway is versus the pediatric airway. In other words, it's more toward the front of the body in the adult. So if something goes in this airway, it's easier in the adult for it to go down the esophagus, but in the child, it's more of a direct line. That makes sense to you? So it's funnel shaped, and it's straight. Pediatric intubations are a challenge when you go to paramedic school because they look different. When you look down in there, they look different. Fortunately, I never had to intubate very many children compared to the adult. And I'm thankful for that. So we've already talked about these. I think I just mentioned all of that. Predominantly nose breathers. They breathe fast. Y'all have any questions as I flip through this, please don't hesitate to ask, but we'll get through some of the anatomical differences and take our break. High O2 demands, because they got really high metabolism. I think you can understand that. Another thing you need to be aware of, as they get younger, they have a kind of an underdeveloped set of intercostal muscles and diaphragm, so you could see some belly breathing in that. With that belly breathing, putting them in what we call a papoose board. So some ambulances carry a board that we can immobilize a pediatric patient, especially in trauma. We call it a papoose board. If you don't have that, you remember the green KED thing you got people out of the car with? That's real good for also swaddling an infant. But if I do that around the infant and put pressure on their belly, I may cause airway compromise. So don't give that trade-off, because we certainly don't want them to stop breathing. Okay. Heartbeats fast. All this stuff you already know now. Cap refill is now significant. Remember, in the adult, we had to take cap refill with a grain of salt, meaning it may or may not be an accurate indication in the adult. It's a very accurate indication in the child. So one of your assessment techniques of a pediatric will be check cap refill. You cool on that? So it shows up pretty easy on a kid compared to the adult. So be sure you check it. I don't memorize this chart. I've never memorized this chart, but I just want you to realize that the younger you are, the faster your baseline heart rate should be. About 10 years old, it becomes more adult-like. So just know that milestone. Around 10 years old, the heart rate should be adult-like. Infants, over 100 is preferred. Neonate, most definitely over 100. Remember, you do CPR at what heart rate in a neonate? If it falls 60 or below? Sure. So it should be fast. Notice where it comes from. The Pediatric Advanced Life Support 2015. And so Stephanie teaches that about once a week around here. No problems there? Can we move along? I've already talked about this as well. Remember the fontanelles. Their development is almost development meant to fall. So if they get a head injury, can the brain swell because of fontanelles? Yes. Are they pliable? Yes. You don't really see the broken bones. I'm not saying the bones can't break, but you really don't see broken bones in the real young age groups. Everything's kind of meant to fall because you were learning how to walk. You're like, how'd they get through that? Well, they're meant to fall. They're designed to take the blows. Now, if I get a pediatric, especially a young one, with broken bones, angulated fractures, what I need to be highly suspicious of? Abuse. If I've got an 8-month-old with a broken tib-fib and the caregiver dude says, he fell off his tricycle, what's the problem? 8-month-olds don't ride tricycles. The story needs to match the injury pattern. So remember, they can't talk. They can't tell you what happened. Your only alternative is to ask somebody on scene. If the story doesn't match, then you got to start down the abuse road really quick. Some people, by their calm, loving, everybody's good, everybody's inherently good, nobody would do this to somebody else, you're going to get in trouble. If that's your mindset in this business, you'll get in trouble. It's almost like I have to suspect abuse anytime I go out, and that's a bad way to live, and I don't like living that way, and I try not to live that way, but I also can't be blinded by things that just don't make sense. So please be aware of things like that as you go forward. That just does not make sense. The ribs are also underprotected, so you get a lot of trauma with the liver. The liver's big. So the diaphragm muscles and the intercostal muscles and the abdominal muscles are less developed, so all those things are more prone to injury. If you do see a broken bone in a kid that's not finished growing, your orthopedic people or your physicians are going to worry about something called a growth plate. It's also known as the epiphyseal plate. Your bones grow from the middle out, and they get longer as they grow out. And as they're growing out, the middle part of the bone hardens, and between the hardened area of the bone and the now growing bone, there's a plate there called a growth plate. If that fracture occurs in that growth plate, it's going to take an orthopedic pediatric specialist to go in there and do surgery on it, because if the growth plate is broken, that limb or that bone could stop growing like it should, and you end up with a shorter arm, a shorter leg, or some things like that. You really can't do anything about that. You need to splint it as you see it, but just understand that we have growth plate concerns. And if you have a choice, I'd rather take the child to a hospital that can handle pediatric orthopedics, if you have that choice. You may not have that choice in your community, but if I'm in the Dallas region, I'm going to go to a children's hospital with these breaks. You can go TMC with them. They may or may not address it depending on where the break has occurred. If it is in the growth plate, they'll ship them out. Do it somewhere else. You have any questions so far? A lot of this we've already talked about, so I don't want to waste your time, especially here toward the end going through this stuff. No? So that's anatomical differences between pediatrics and adults. Take your break. I'm going to get through the slides and get down to the specific conditions. We'll come back in and we'll get on that. Okay? Yes?
I didn't see this one posted.
Okay, I'll get it up.